respected chairpersons, and my dear friends. At the outset, let me thank Songho and other members of the organizing committee for inviting me to this wonderful, very stimulating meeting. This morning, I've been asked to speak on use of AVP II for large and long PDAs in infants. And what I'm going to do over the next 12 to 13 minutes is to share our initial experience with you. All of you will agree with me that this particular subset is technically challenging for various reasons. First and foremost, the vascular access is small. So you are limited by the use of smaller sheaths and hence smaller low-profile devices. Most of these babies have very large torrential flow across the ductus, and therefore stability of the device becomes an issue. For many years, we were using ADO1, and the biggest problem of using ADO1 in these small babies with large ducts is that the retention disc on the aortic side could compromise the aortic lumen. And when ADO2 came into market, we thought that we have found the answer to this problem. But unfortunately, ADO2, rather than compromising the aortic lumen, started compromising the lumen of the left pulmonary artery. So this is how we started our program in 1998. And we were quite ignorant, I must say, and didn't really realize what ADO1 can do in these small babies. This is a newborn who had a pulmonary stenosis which was dilated, and we thought that the duct would get closed, but it did not, and deventilation was difficult. We brought him in the lab and used the ADO1, and we really didn't know that what it can do, but this particular patient went off well, and we kept on doing this in infants, and maybe for 2 or 3 dozen babies, probably the luck was favoring us and we had no problems. Till such time, we came across this patient. This is not a very large duct, but a long duct definitely. And when we tried to use a ADO1, this is what actually happened. The device fell into the aorta because it could not be taken right into the pulmonary side. And we had to call in our surgeon who removed the device and closed the ductus, and the recovery was uneventful. As I said earlier, with the advent of ADO2, we thought that we have found the answer. And this is one case with a large and long ductus. This child also had Down syndrome, wherein we have used ADO2 very successfully. And you can see it's beautifully sitting into the aorta without causing any compromise on the aortic lumen. And just a little bit of the disc into the LPA origin, but the LPA flow is unobstructed. So we did maybe half a dozen cases using ADO2 till such time we came across this patient. And you can see that the whole disc has fallen into the LPA origin. And this was not the case when the disc was on the wire. Only when we released it from the cable that it falls, and by that time it is too late. This patient underwent percutaneous stenting of the left pulmonary artery with very good results. So after these experiences, we decided that all our patients with long and large ducts who weigh less than maybe 6 or 7 kgs will go to the operating room. What then revived our interest in again thinking about percutaneous closure? It was a report from my good friend Krishna Kumar in JSCC interventions, wherein they used coils to take care of large ducts in newborns and preemies. And then my other good friend from Taiwan, Yunqing Fu, I saw him close many long and large ducts in preterms and in newborns using AVP II as well as AVP1. And Ivan Zan's paper in catheterization and cardiovascular interventions using AVP II for closing ducts in preemies was really impressive, and that started making us rethink about our strategy of surgical intervention. And so we thought that we could again go back to transcatheter intervention. And the 2 other important developments were the advent of AVP II and the advent of ADO2 additional size. We embarked this particular journey starting with Amplatzer Vascular Plug 2 because it was very easily available in India, unlike ADO2 additional size, which was not available. And the second important thing is the ADO2 additional size, you can close ducts up to 4.5 or 5 millimeters at the most, certainly not beyond. The biggest advantage of Amplatzer Vascular Plug 2 is its very low profile, can be delivered through 4 French sheath. It has no polyester, that's why it is soft. It has no aortic retention disc, so no question of compromising aortic lumen. It has no pulmonary retention disc, so no question of compromising pulmonary flow. The only limitation of vascular plugs is the length of the plug. Because when you have no retention disc, the only way to retain the device is with the help of the walls of the ductus, which act as a supporting structure. And if you have a short duct, not sufficient enough to support the length of the vascular plug, you will end up with embolization. So now I'll share with you some of our data. This is 1-year-old child, repeated respiratory tract infection, bounding pulses, large heart, and continuous murmur. And this is a fairly large ductus. You can see it's more or less cylindrical with a little bit of bend in between. And this measured around 4.5 millimeters, and we had a choice of 6 versus 8. We preferred to use an 8 millimeter vascular plug that shows a complete closure when on cable. This is for looking at the pulmonary arteries, which look quite good, unobstructed. And this is the final angiogram after release. I think the result looks quite good. This is a 3-month-old child weighing 3.2 kgs, had shortness of breath and feeding difficulty and 1 episode of pneumonia, has a large left to right shunt at the ductal level as evident by a flow murmur across the mitral valve. You see this, anatomically, this duct is around 3.8 to 4 millimeters, but for a child who is 3.2 kgs, I think it's a sizable duct. And you can see that the pulmonary artery pressures are just subsystemic. So angiographically, it's a pretty large and a long ductus. So we thought that we will use a 6 millimeter AVP II in this case, and you can see that it sits beautifully inside the ductal ampulla with just the pulmonary artery disc ending up at the origin of the left pulmonary artery, but nowhere close to the lumen of the left pulmonary artery. And once we were happy with the position, we have released the device, and you can see that there is a very good result, excepting for a little bit of foaming. And more impressive is the echocardiogram. You can see that the device is sitting beautifully inside the ductus with no compromise on the LPA flow, no compromise on the descending aorta. This is the third case of an 11-month-old child with repeated respiratory tract infections, again bounding pulses, cardiomegaly, and a continuous murmur. And this patient had almost systemic pulmonary artery pressure, maybe 80% of systemic pressure without much restriction. And this measured around 5.1 millimeters and pretty long, around 7 millimeters in length. So this is the angiogram, and we put in an 8 millimeter vascular plug. And you can see here, really, this length was not absolutely adequate, but just enough. And we were lucky that despite a tug test, the device was quite stable. And so we decided to release the device. And this is the final angiogram. And you can see that a part of the device does come into the main pulmonary artery. But I think a little bit of fortune for the patient that the device remained stable. And more surprisingly, you see echocardiographically, the flow in the left pulmonary artery is still very, very laminar, and see the flow in the aortic isthmus showing no evidence of obstruction whatsoever. And this is the last success story, because I'm going to conclude with one of our failures as well. So this is a 7-month-old child, severe failure to thrive, and a very large ductus. Systemic pulmonary artery pressure, and this duct measures around 5.1 millimeter. So 5.2 millimeters. So we thought that we will use an 8 millimeter vascular plug, angiographically very large ductus in lateral as well as in RAO projection. And this is the 8 millimeter vascular plug, which is coming into the ductal ampulla, occupies the whole of the ductus. And once we are happy with the position of this device, we have released the device. And you can see that this is the final angiogram, which has closed the ductus completely. And again, very impressive echocardiographic pictures with ductus remaining, with the device remaining inside the ductal ampulla without having any compromise of the LPA or the descending aortic flow. And this is the last case that I'm going to share with you. It's a 1.5-month-old child, rubella syndrome. You know, just trying to extend the indications, but this is how you can land yourself into some problem. 2 admissions for heart failure already, symptomatic despite adequate medical treatment. So basically, you can see this. See, this is a very large ductus in a 1.5 month. And I think what we misjudged was the length of this ductus. This is not a very long ductus. And you can see here, this measures around 4 millimeters, and we got the length around 6 to 6.5 millimeters. So we do an angiogram here, and you can see that it's a pretty large duct for a 1.5-month-old child. So we came with a 6 millimeter AVP II, and you can see that it just doesn't even sit. It just comes into the pulmonary artery. So we thought that we probably released the device a little too proximally. So this is the second attempt, releasing the device distally. It does sit for a little while, but after a few seconds, again drops back into the pulmonary artery. So we gave up the idea of using 6 millimeters, and we went ahead with an 8 millimeter device. And you can see 8 millimeter device sits beautifully. There is absolutely no problem. Angiographically, it is perfect. Little bit of disc protruding into the aorta. But we take a good pullback, and you see that there was no gradient at all. And unlike in AD01, the vascular plug has no recoil because the cable is so fine that when you release it, it will remain where the device was. So if there is no gradient now, there is unlikely to be a gradient after release. And so we usually do a tuck test. And what happens in a tuck test is that this device gets prolapsed into the pulmonary artery. So we give up the idea of closing this, and this patient was sent for elective surgery. And this is how echocardiographically baseline. This is the 6 millimeter device which stayed there for a few seconds, and you can see that the device comes back spontaneously into the pulmonary artery. That's the 8 millimeter device which sits beautifully, little flow acceleration in the LPA. But when I push the device, there is hardly any flow acceleration. There is no flow acceleration in the isthmus, but the tuck test failed, and that's why we had to remove the device. So this is the experience of 14 patients, 8 males and 6 females. Average age was 7.3 months, weight just above 5 kgs, PDA diameter over 5 millimeters, and the PDA length of around 7.5 millimeters. And you will see that most of the patients had severe pulmonary hypertension. We have used anywhere between 6 to 10 millimeters of vascular plug. Most of the times, the device size was much less as compared to the size of the PDA. If you look at the ratio, the device to PDA ratio was around 141%. And what we found that those in whom we were successful, I think the PDA length was sufficient enough. And in those whom we failed, the PDA length was much less than what we would have allowed. Procedural success was in 12, embolization in 1 who went for surgery, and failure of the procedure in 1 who went for elective surgery. So in conclusion, ladies and gentlemen, transcatheter closure of long and large PDAs in neonates and infants is challenging. AVP II can be used safely in selected group of patients. As I said earlier, and I would like to emphasize, that length of the ductus is crucial to hold the device in place. You should never accept any gradient across the left pulmonary artery for 2 reasons. One is it could be actually compromising the left pulmonary artery flow. And the second, even more important, is that that may be an indicator that the device is not fully supported by the ductal ampulla. I think this procedure in small babies, you should have a surgical standby with a very supportive surgical colleagues. Now, whether, given this data, whether we can extend the indications of using AVP II in newborns and in preterms remains a big question mark, and only time will tell. Thanks for your patient hearing, ladies and gentlemen.